talk about managing a SWAT style team to manage health informatics projects. So COVID-19, one of the largest healthcare crises that the world has experienced in modern day history. It was a privilege to collaborate and develop some creative solutions for our frontline workers. We, much like them, had found ourselves in uncharted territory that was complex to navigate for me. It was a real opportunity to lend a helping hand, to step outside of my comfort zone and step into that uncertainty with some courage to support as best as I could. So what does it look like to apply project management in a crisis? So with the pandemic that was fast upon us and everyone in the healthcare sector reacting to provide a response, there was a critical need to quickly implement technologies that support the ability to provide care at a distance. This for us was required for patients who were in our care facilities and those who required access to the healthcare services from outside of the facilities. And there were unique requests that were being presented to us daily from the various healthcare providers, support workers, admin staff, corporate staff. So to respond to the high volume of requests that were coming in, we decided to follow a critical path process. That helped us to focus on getting technology solutions out in some orderly, calm way. But you guys can all imagine established workflows and processes that have taken many, many years to implement were going to be changed overnight. And that was no easy task. So the first step in the critical path process was to identify and assess the priorities that were being presented to the health informatics team. The chief medical and the chief nursing officers, as well as other clinical executive leaders, really played a key role in helping us ensure that we were working on the right priorities. We then ranked these and performed critical path analysis to identify the shortest path that was going to be available for us to implement those technical solutions. The team did perform analysis on every request to determine if they could maybe even group some of the requests that were coming in for efficiencies. Maybe there were some economies of scale, or we could expedite delivery. The final step was, of course, to implement the items and do it quickly. This took people to really step outside of their regular jobs, roll up their sleeves, and just have that attitude of getting the job done. For example, I myself went to install iPads in a COVID and ICU unit at a site. I had no idea how to mount, secure, and set them up, but I was able to piece the information together from some quick reference guides, some YouTube videos, and got the job done. When we're following critical path, I think an important thing to note is that when we're dealing with a crisis, it's still important to form project structure and an approach. It really grounds the work that we do as PMs. And so regardless of the chaos that might be happening sort of around us, we're really able to focus and not constantly be reactive. So when we do this, it is easier for us to see the path forward so that we can help guide the work that's actually required. It's also helpful for us to, even though we need to understand the technology side of things, so applications and infrastructure, we also need to be able to identify the impact of introducing those technology solutions into workflows, processes, the collaboration and exchange of information that might be occurring between people as well. We as PMs need to make sure that we are not adding other issues into an already complicated situation. So as we began to create sometimes what were unconventional solutions, we stayed true to the digital platform and ecosystem that was already in place for us in our organization. There was no time to reinvent the wheel for really any kind of work. We extended solutions. So for example, we already had MS Teams. We extended it for secure messaging between providers. But ultimately, we were leveraging what we had. And this placed a really positive emphasis on our informatics solutions because the team already had the knowledge and experience in that ecosystem. So it was a case of extending capabilities and bringing solutions together. And that, again, I think is a really important point because it avoids the pitfalls of being reactive, which can just add to all the chaos. So staying focused on the workflow and the technology fit of the solutions really helped us to build an integrated, coherent digital workspace that we've actually continued to grow and develop post-pandemic. So as I've said, managing a project during a crisis, it still requires that grounding of project structures, approaches, processes, and tool sets to be in place. We still, as a team, analyze the impact to the patient in their care journey. We still created use cases to inform user interactions with different systems. We still attempted to understand requirements in order to inform the solutions and technologies. The only real difference was that we were doing this quickly. So instead of lengthy documents and working sessions, we were very targeted in our approach, asking key questions, using simple tools like Whiteboard. So how does this look in a crisis situation? To support the SWAT team to work quickly, efficiently, and for communications to be fast, we created a war room type concept. So essentially, in a crisis, the key thing is really to communicate with team members quickly and with some clarity. And the war room concept really allowed key decision makers, developers, analysts, all to be in a room together. Problems were being discussed, resolved on the spot through that quick collaboration. We were using whiteboard sessions to help with brainstorming, and was also being used to create the focus for those daily activities that needed to take place. So we took a light documentation approach. It wasn't eliminated completely. We still needed to be able to reference back to why technologies were being designed and implemented in a certain way. And of course, risks and decisions all still needed to be managed. So none of that from a project management perspective goes away. It's just how you do it, it becomes different. So I'm going to give you guys a quick example to walk through that process. So we were looking at critical care rounding. Okay, so we were able to assess it quickly. We were able to determine that providers needed to remotely connect with other providers during the critical care rounds that were happening on a daily basis. The core requirements that we were able to identify was that there was some allied health staff who needed to attend the rounds remotely, with some on-call triage intensivists who were at community hospitals. We understood that this was a multidisciplinary team. We also understood that the environment in which these critical care rounds were taking place was super loud, so that sound was going to play a core part of it. So how did that translate into our solutions and technologies? We took some iPads, we mounted them onto mobile carts with some mounted speakers. We uploaded multiple video conferencing software, as well as software like translation services to help support that process. We also added multiple different profiles on those iPads so that they could be used for multiple different purposes. So example, patients could use them to connect with family members, and providers could also use them to connect with other providers and patients as well. So that's just a quick example. And I am way over time, as you might imagine. So I'd like to thank you all for this opportunity to share my experience here with you. And I hope you've enjoyed learning a little bit about what it takes to manage a crisis with a team called SWAT. Thank you.
Thanks, Rav. There. Well, thanks, Rav. I'm going to take a little bit of a different approach. I'm going to do a sort of the highlight reel of a couple of the projects that we worked on here at Halton. Thank you for the earlier introduction, and let's just get right into it. Just for some background on our organization, we're a large group of community hospitals just west of Toronto. We support a population of about 500,000 people. I'm going to briefly talk about a couple of the pandemic support projects I was involved in the last 2 years. To start, we're going to talk about what we called field hospitals. Early in 2020, our healthcare organizations anticipated surges in patient volumes, and we saw the need to expand temporary hospital units, and we called these field hospitals. This is a temporary tent for a field hospital going up in the parking lot of one of our neighboring hospitals. At Halton, we were fortunate enough to have 2 hospitals that have opened in the last 5 years. And they were designed for a 30-year life cycle, each of them. Part of that plan included a few 100,000 square feet of undeveloped space in each of them that was built for future clinical growth. They already had fire systems, heating, plumbing roughed in, so we decided that these spaces were best suited to outfit quickly for our expansion. This is the same space about 6 weeks later. With the temporary structures we built to accommodate 40 patients at a time in this unit. We called our design an in-field hospital. One common misconception that the public had at the time was that we were building these structures for COVID patients. You can probably assume from the areas or from seeing the tents, these aren't plumbed for medical gases. They're also not ideal for infection control. They're actually intended for a typical post-acute semi-ambulatory patient to free up our standard units for better isolation of COVID patients. Though the equipment's the same as what you'd find in a typical nursing station, supply for practically everything was constrained at the beginning of the pandemic, and it's still not a lot better today. We were fortunate enough to have a meager supply of spares that were originally intended to refresh aging equipment on the units. So we put those into use right away. We already had basics like monitors, PCs, printers, medication carts. We quickly assembled them and we put them all in service, really crossing our fingers and hoping that the old equipment would last just a little bit longer. Early in the pandemic, like Rav mentioned, we found the need to be flexible to projects that had scopes that changed sometimes multiple times a day. And we had to improvise with what we had on hand, not just with technology, but even furniture and building supplies. Once these spaces received their first patients in late 2020, they've been at capacity ever since. Next significant project we undertook was part of the early vaccination clinics. In early December 2020, we were informed that we would be one of the province's phase 1 vaccination sites. At the time, the province was still building out tools to use for scheduling and dose tracking, so we had to improvise with our own community-wide scheduling systems. Security was also a huge concern at for the initial sites. In the early days, this was the most valuable substance on the planet. And it was in short supply. So we were on high alert for cyber attacks. We reviewed good cybersecurity practices with all the staff involved. And we were also alerted to physical threats to the vaccine supply from theft and intentional sabotage. That's why if you look at the dates on this slide, you see December 11th, we were notified. The media reported it on December 18th. The media was reporting purposefully 7 days behind what was actually happening on the ground. The first protocol we received was that the second dose would be reserved for a patient when they showed up for the first dose. And we expected enough doses for about 10,000 people. We prioritized frontline healthcare workers, emergency responders, and individuals in congregate care settings like long-term care. Based on the supplied numbers and the interval between doses, we calculated we needed to administer 150 doses a day. After administering our first doses, we heard from other sites that if they were careful, they were able to pull a 6-dose from that 5-dose vial. So scheduling was a really rigorous task, and these vials are stored at very low temperatures, and they take a long time to acclimate and prepare. So we quickly had to adapt our scheduling and workflows to account for this extra volume, since once that vial acclimated, it had to be put in arms or poured down the drain. In our first few days, there were about 50 extra doses prepared that we had to quickly find willing recipients in frontline care within the hospital so that they weren't wasted. And then we built these new ratios into our scheduling system for the upcoming days, so we didn't risk losing these valuable doses. Over the Christmas period, provincial guidelines changed again so that we didn't reserve that second dose anymore. And everybody received orders to ramp up all clinics to as much capacity as we could push through. So we redesigned that initial small meeting room space and took over our auditorium and estimated that we could handle 1,000 a day. We eventually found that observation and discharge area was our rate limiting step. So we moved those roles into our main lobby. With this layout, we were finally able to get up to the 1,000 a day target just within a few days of getting the orders. We've now closed down and dismantled the mass vaccination centers. And coffee shops for these new clinics. So that's a really brief overview of 2 of our biggest pandemic support projects. Thanks for listening, and I'll turn it over next to our next presenter.
And great to follow Joe Walsh. I was wondering if I was going to hear a bit of guitar there, Joe. So land acknowledgement, I'm calling from the interior of British Columbia. I work with Interior Health Authority, and I recognize and acknowledge that I'm joining you from the traditional, ancestral, and unceded territories of the 7 Interior Region First Nations. The Interior Region is also home to 15 Charter Métis communities, and it's with humility that I continue to strengthen relationships with the First Nations, Métis, and Inuit peoples across the BC interior. So I'll tell you a little bit about some of the projects that I was supporting in the early months of the pandemic. So this would be starting kind of maybe mid-March and then carrying through to the summer months. So supported a telephone screening tool for COVID-19, developed some virtual care guidelines for the home health teams, as well as the community diabetes service teams. And then I'll tell you a little bit about our remote patient monitoring projects in the interior. So the telephone screening tool. So just for context then, the community clinicians that use this tool, they provide care for patients and clients in their homes. So this includes our home health teams, nursing and rehab predominantly, and our mental health and substance use teams, again, who are supporting clients in their homes or where they live or where they're meeting them. So we needed to develop and implement a process to assist community clinicians with how to select the appropriate personal protective equipment. Of course, there was a shortage of PPE at the time as well, which is a whole other presentation. What was interesting about this project, we anticipated that the advice and the direction was going to evolve really, really rapidly. I think in the very, very early days, right, we had maybe 1 case, 2 cases in British Columbia in the early time, right? We did not have community spread at that point. So, what we did is we designed the electronic screening tool in our electronic health record that everybody uses to document. And we aligned with the BC CDC online self-assessment tool that was there. So we're going to, I think, hear about that from Jerome, I believe. So anyway, yeah, we knew the advice would change. So we thought, you know what, let's just, we can't just create paper handouts. That's why they really decided to do something in the software. And each week we updated it. The screening tool also obviously guided clinicians with the appropriate advice to give to clients on their reported symptoms and exposures that they assessed in their tool. So we went live on March 24th. I think briefly from a project lens, what I would say is it was actually quite straightforward. What we needed to do was very, very clear. We had a very clear scope of what we were trying to accomplish, and we had a dedicated team that focused on it. I think we worked on it for 3-4 days. We had it tested, communications were written, we implemented. It was intense, some long days, but from a project lens, it was quite successful. Virtual care guidelines. So I worked on those in April. The purpose really was to provide guidance for the clinicians regarding the clinical assessment and judgment that they needed to apply. It was basically walking them through the steps on how they determined whether they really needed to prioritize a face-to-face visit for a particular client's needs, a face-to-face visit for home health or for diabetes. And that was the guidance that they were looking for. They didn't just switch everybody over automatically necessarily to virtual care. A key overarching standard of care was that really all of the standards of care, professional standards, and the best practices guidelines continued to be applicable even when providing healthcare services virtually. That was an overarching standard. Briefly, the categories in our early set of guidelines, right? The client-provider relationship, we clarified, reinforced the duty of care, things to consider for client suitability, right? When would you not ever do a virtual visit? Some of those things. Informed consent, privacy, how to identify the client and how to validate their email. So we were trying to uphold privacy. The guidelines and the rules and the structures that were in place, and other pieces around clinical documentation, devices, contingency planning. Something happens during your visit, and what do you do? So stuff was happening so quickly, and we got tremendous feedback on the guidelines and the benefit of them. The use of, and then we obviously just another example of sort of walking people through visually. Then where were your decision points, and what were the things that you needed to consider in planning your visit with your client. And then just briefly, remote patient monitoring. We had a very pre-existing small program for heart failure patients. We did public health and interior health did trial the provincial solution for contact tracing and management. But after about a week and a half, that didn't continue. There were just too many challenges with their workflow, and particularly having to double document and the lack of integration with Panorama. Island Health did lead the development of protocols for the management of high-risk respiratory patients, and managed quite a number of patients through their HHM solution. And we were exploring that, but we didn't proceed. We did not have the regional infrastructure and capacity to support it. It wasn't realistic to bring a group of RTs and nurses in to start managing, hundreds and hundreds of patients across the region when they were already stretched doing other things. IH also went a different approach with developing respiratory clinics as well, and did local assessments. But it was interesting to hear some rural primary care providers they were brilliant, just establishing less complex solutions to monitor their high-risk patients. They were getting them to text them their symptoms back and forth, send them pictures of their blood pressure readings or their oximeter readings if they had it. So I thought that was quite noteworthy. So yeah, happy to take some questions afterwards, and we'll hand it over to Jerome in the interest of time.
It's about applying design thinking to problem solving and project managing in an emerging call-taking issues. So I admit that the topic, I'm trying to tackle multiple topics here, and I probably don't have enough time to go through all of this in detail, which is fortunate. So what I'm trying to demonstrate here is about using design thinking, about project management in a telehealth perspective. And so as a caveat, I will really just focus my discussion on those areas. One question I'd like to tackle first at the very beginning is, why is this relevant? As Susie and most of the Joe and Rav have mentioned here, the pandemic was a game changer, especially for telehealth and digital health. In a nutshell, the pandemic and our ability to respond to that from a telehealth perspective really put the awareness of the public on what HealthLink BC is. So it was our greatest marketing. But also now we have these problems where the public's we're never going back, right? Public's always going to be using telehealth. In fact, studies have shown that and supported this view that there's expectations in the future that for expanded telehealth use, and where telehealth, there's a potentials where you can address the key challenges in providing health services during a pandemic such as COVID-19. So I think this is why it's relevant. We're trying to understand what the impact is for telehealth services. So a little bit about HealthLink BC, if you're not familiar with that. HealthLink BC, we provide non-emergency health information and advice in British Columbia. We deliver high quality digital and telehealth services across the continuum of care to British Columbians and healthcare providers. And we try to see that we try to bridge the gap between and after in-person community services to best support the patient in their health optimization. And we try to support healthcare providers in their aim to achieve the highest clinical outcome for their patients. I have there a link if you'd like to see more about HealthLink BC, but in particular, the service I'd like to focus on is 811, and 811 is our the service that we provide free of charge in the province. It's our phone line advice. You can speak to a health service navigator who's not a clinician, and they can help you find health information and services, or connect you directly to a nurse or a pharmacist, or our qualified exercise professionals, or a pharmacist. So that, in a nutshell, is what 811 is. In terms of, and I'm happy to expand on what the other services are after this talk. So I'd like to go now to what the situation is. If you recall, we all know what happened in 2020, the start of the pandemic. We all lived through that, right? Just jumping back in, if you recall the situation here, the one is from Vancouver's Awesome, the other one is from CBC, and it was a bit disheartening at that time, where you can see news headline like this, where don't bother calling the BC government's 811, right? To quote the line from Vancouver's Awesome, you definitely do not want to call that line. because what you'll get is a busy signal. And so if you recall, that was what's happening 2020. I I'm glad that's not the case anymore. But what happened at that time, you know, with every public health announcement, there's a call to action to call 811. At that time, it was very early in the pandemic. We saw massive increase in demand for our services. We needed to meet the demand, but our services at that time have not yet been escalated to the point where we can respond effectively to the pandemic, right? So that was the situation we had around that time. So in addition to that, there are other factors that may not really be relevant to this talk, but other factors that would have affected the way we handled those during the pandemic would be, at that time, multiple sources of information were coming out, right? Health authorities were releasing information. We had to respond to the pandemic, so we had to rapidly hire staff, onboard them, train them on the resources. And so there was potential for confusion in those areas. So what we needed to do at our from HealthLink BC is we needed to meet our mandate, our task objectives. We need to provide information that aligns with the provincial public health initiatives and objectives, but we also needed to make sure that we support in particular, these two core areas: content for HealthLink BC website and for 811. So I'm going to focus my talk about 811 in particular. So this is very early on. We needed to know how to meet the task at hand, right? How do we answer the problems and issues we have identified, and we needed to understand what kinds of calls our call takers were receiving. We needed to understand how our call takers were answering these calls. And so very early on, we made the decision to adapt design thinking principles. How I came across design thinking was kind of like not really structured, but at that time I was hiring for a user experience lead, and I came across design thinking principles. So I'm just saying that because as a caveat, I'm not an expert. I would like to see myself though as an advocate in the organization for design thinking. Right? So what is design thinking? It's really an iterative and a non-linear process. It is a process for creative problem solving, and it allows us to understand our users, to challenge our assumptions, to define the problems, and to rapidly prototype and test our solutions. So the goal here for us would be to identify what strategies we can do now that we are aware about the problems we have identified in the beginning. So the very first step we were asked to do is understand the problem. We need to ask what the right questions. In this case, we need to know the what, the how, and the why. So for understanding the what, we need to ask these questions in particular because we needed to we work in silos, and unfortunately that was the case at that time. I create work for another team that does not report to me, so I create impact downstream and upstream. So we want to create concrete observations that are free from all these assumptions that I have about this is how they should be responding. This is how they should be taking this phone call. This is how they should be answering a specific question. We need concrete ways to observe, to document how they use the information we provide to the floor. In the what, we record the details. We actually audited phone calls from the public. We actually recorded the interactions of the call taker with the client. So we were able to capture that concrete detail there. In the how, we try to analyze how the person is doing with the information we have provided. Is it taking them a lot of effort? Are they finding the process easy? We also employed at this point interviews so that we can understand better. We can go to the core of how they were trying to use the resources that we provided. We also were able to lean on the supervisors and expert staff to document the process for us. In the why, we want to understand why they do it this way. So we make educated assumptions on why they prefer to follow this way. This would also be supported by the interviews. So in the end, we were able to really understand the problem, and we realized that the problem was there's two areas of focus two problems we can provide solutions to, which is there is an overload in information, and there is also an increased call handling time. Both are interrelated, and solving one and without solving the other would cause the same level of problem. So we needed to solve both. So now that we understand the problem, our next step would be to defining the problem. So we use human-centered design, human-centered analysis. It's framing our problem statement according to specific users, their needs and their insights. It's very similar to human-centered design. I know I've taken that course at UVic in the past. We just needed to satisfy the needs of the user from both a functional and emotional and meaningful way. So at the very broad level, our problem is how do we support the call takers to complete a call in as efficient and accurate manner as possible. And once we have the problem, we wanted to create solutions, formulate solutions. So we use one key insight that we have at this point, although we were trying to adapt design thinking methodologies, is we wanted to make sure that we only use tools that are familiar to all of us. So nothing fancy, nothing crazy. We brainstorm, we use brain dumping and mind mapping exercises primarily. So meeting as a project team, meeting with the stakeholders as well to ideate solutions. And what we wanted to do at this point is really just to ask questions, provide solutions, and making sure that we are able to capture ideas in as much as in as detailed manner as possible. And we employed, once we have a possible solution in mind, we employed prototyping and testing. To do that, we needed to gather data, qualitative data, primarily through the interviews we already have. But we also wanted to document quantitative metrics like call handling time and and other relevant data. So, for example, we use analytics to identify what are the top calls, and to identify areas that have too much information, which means that are there competing sources of information. So, for example, symptoms on PCCDC might be different from the symptoms from Health Authority. So, I wanted to know what the pain points are. We wanted to also know what were the extreme calls, where one call may actually tie up a call handler for too long. So the results of this, we're able to develop an algorithm that that we initially developed just for non-clinical call handlers, but eventually expanded to the nurses. And our algorithm was able to tailor the information for what our staff needed. And that, I think I'm over time as well, so that would be it for me. I'm happy to answer questions about that. Thank you.